Yes, sir.
See, the topic for you is test used in cardiopulmonary. So the basic test is ECG. So today we will discuss about ECG. I think there are network issues. Could you see the slides?
Sir, not right now. Yes, sir. Yes, sir. Now I can see. Yes.
Fine. See, ECG is electrocardiogram. It is the procedure in which electric action potentials are collected from the heart. They are amplified and traced on a ECG paper. So that is about ECG. Now to understand the ECG, first of all, we have to understand our conduction system of heart. See, we have four conjunctional tissues: sinoatrial node, atrioventricular node, bundle of His and bundle branches, and Purkinje fibers. Now, how the normal impulse conduction occurs? See, for if you are having a normal pacemaker, then sinoatrial node is in the pacemaker. That is, the heart is in sinus rhythm. So the impulse is generated in the sinoatrial node. Then the impulse goes to the AV node, atrioventricular node. Now at the atrioventricular node, there will be a delay of 0.08 seconds. After delay, it will go to the bundle of His and bundle branches. Now after bundle branches, Purkinje fibers, it goes to the Purkinje fibers. Now here you have to understand that whenever an impulse is coming to a region, that region will be polarized. And when the impulse leaves that region will be depolarized. So, for example, now from SN node it comes to the AV node. It means your right atrium and left atrium are polarized. Then when it leaves AV node, right atrium and left atrium are depolarized. So in this way, the conduction system occurs. Now, what is cardiac cycle? See, ECG is nothing but paper presentation of a cardiac cycle. So the series of events that occur in the heart during each heartbeat is called cardiac cycle. The various major series of events are: there will be contraction and relaxation of different chambers. In one cardiac cycle, what exactly happens? There will be contraction and relaxation of different chambers. There will be opening and closing of different valves. Because of the closing of the valves, there will be occurrence of the heart sounds and blood flow through the different chambers. So these are the events that majorly occur in the cardiac cycle. Now, when we put the events in the form of an electrical events, we have four events: atrial systole, which is for 0.1 second, atrial diastole 0.7 second, ventricular systole 0.3 seconds, and ventricular diastole 0.5 seconds. Considering our heart rate to be 72, one cardiac cycle takes 0.8 seconds. Nodal delay. When the impulse reaches atrioventricular node, it is not immediately spreads into the bundle of His, but delays for 0.08 seconds. This is called nodal delay. Now, why there is a nodal delay? The nodal delay ensures that atrial contraction is completed before the ventricles begin the contraction. This ensures proper filling of the ventricles. Now, what is an electrical event? I have told you that ECG is nothing but picking up of electrical events from the heart, amplifying it, and then tracing it on the ECG paper. Now, what is an electric event? When the cardiac muscle has to be contracted, it must be excited by depolarization. And when the muscle has to relax, it undergoes repolarization. So contraction is known as depolarization and relaxation is known as repolarization. So in terms of electrical events, the cardiac cycle includes atrial depolarization, atrial repolarization. That is atrial systole and atrial diastole. Similarly, ventricular depolarization and ventricular repolarization. ECG, as I told you, it is the graphical recording of the electrical potentials in the heart during cardiac cycle. These potentials are picked from the body surface, they are amplified and recorded by the electrocardiogram. Now, what are the components of ECG? We have electrodes. Basically, 4 electrodes are there, which we place them on right wrist, left ankle. The 4th electrode is placed on the right ankle, which is used for earthening purpose. Then we have a lead selector. By rotating the lead selector, desired lead is obtained. See, ECG, normally we have 12 leads. In one ECG graph, we will be having 12 leads. So this lead selector will, we will be able to select which lead we want, ECG in which lead. Then it has an amplifier which amplifies the electrical potentials. Then we have a galvanometer. This is used for measuring the electrical potential. Then a thermal writing stylus. It is attached to the coil and it moves with the coil of the galvanometer. This stylus is heated in the machine. Now see, if you see an ECG paper, this is actually a gray paper. Actually, what it is a black paper covered by a gray color wax. So this thermal writing stylus, when heated, when the galvanometer coil moves, the thermal writing stylus also moves and it will melt the wax. So as a result, what happened? Behind the black color paper looks like a scribbling. So you get a black line. Actually, it is a gray color coated paper. If you see ECG paper, it's a wax paper. Black color paper covered with gray color wax. So that's the easy. Now coming to the ECG paper. Now it is a black paper coated with gray wax. When heating stylet comes in contact with the wax, it melts and the black graph is obtained. ECG paper has thick and thin lines horizontally and vertically. These are called thin lines and these are called thick lines. Thin lines are 1 millimeter apart, this one. Thick lines are 5 millimeter apart. Horizontally time is indicated, vertically voltage is indicated. The speed of the ECG machine will be 25 millimeter per second. So 1 millimeter indicates 0.04 seconds. So one large box is 0.2 seconds. Vertically voltage is indicated 10 millimeters is equal to 1 millivolt. That means if the graph covers like this for 10 millimeters, then it is 1 millivolt. And if a graph covers like this, that means that graph is 0.2 seconds. Now for every 3 seconds, you have one thick line. These thick lines are used for counting the heart rate. That is, for every 15 large boxes, it is marked by a vertical line. It is used for calculating the heart rate. Lead. Lead is a closed circuit formed by connecting 2 points on the body surface and 2 terminals on the ECG machine. As we have discussed, we have 4 electrodes. One electrode we already placed for earthening purpose. That means right ankle we never collect. We have 3 electrodes, that is right wrist, left wrist and left ankle. So any 2 points on the body connected to 2 terminals of the ECG machine forms the lead. Leads are of 2 types, unipolar leads and bipolar leads. Unipolar leads, in unipolar leads, one electrode is exploring the electrical potentials and the other is indifferent electrode. It remains at 0, that is neutral. Unipolar leads are again 2 types, unipolar limb leads, unipolar chest leads. The unipolar limb leads are called as AVR, AVL, AVF. A means augmentation, V is voltage, R is right arm, L is left arm, F is left foot, left leg. Now AVR, exploring electrode is connected to right wrist, indifferent electrodes are connected to left wrist and left foot. AVL, the exploring electrode is connected to left wrist, indifferent electrodes are connected to right wrist and left foot. In AVF, the exploring electrode is connected to left foot and right, the indifferent electrodes are connected, that is negative terminal is connected to right and left. ECG machine, the exploring electrode is always connected to the positive terminal. Then we have chest leads unipolar. We call it them as V1, V2, V3, V4, V5, V6. Now where we are placing? See, V1 is placed in the 4th intercostal space on the right border of the sternum. This is V1. Then V2, 4th intercostal space on the left side of the sternum. 4:30 तक सर. क्या हुआ सर, कुछ काम है क्या? मैडम हाँ आई है, हॉस्पिटल गई सर. Hold on. ठीक है सर. Sir 63958 22600.
मैं अभी यहाँ रख रहा हूँ, इसमें जो बीपीटी के बच्चे हैं ना सर, उनका क्या स्टेटस में पास है कि फेल है, ये पता करना है. ठीक है, तो अभी रखे हैं, मैं यहाँ बना खुद बोलूँगा.
Hello?
Yes, sir.
Okay, let's continue.
Yes, sir.
So V2 is the electrode that is present on the 4th intercostal space on the left side of the sternum. V3 leave it. V4 mid-clavicular line, exactly mid-clavicular line in the 5th intercostal space. Now V3 will be exactly in between the V2 and V4. Then V5 will be the fifth intercostal space, anterior axillary line. Then V6 will be the mid-axillary line, fifth intercostal space. So this is the placement of unipolar chest leads. Now you have to understand that all the chest leads are positive. Now bipolar limb leads. In bipolar limb leads, they are named as lead 1, lead 2, lead 3. In this, both the electrodes are exploring. So if you look at in this diagram, lead 1 is connected positive terminal to the left arm, negative terminal to the right arm. Lead 2, negative terminal to the right arm, positive terminal to the left leg. Lead 3, positive terminal to the left leg and negative terminal to the left arm. So it forms a triangle. This triangle is called as Ithoven's triangle. And we consider heart is said to be in the center of this triangle. Ithoven's triangle. Now Ithoven's triangle, it is an imaginary equilateral triangle, the apices of which are formed by the roots of right arm and left leg. Ithoven assumed that heart lies in the center of the triangle and produces the electrical current which spreads to the surface. Ithoven's law, very important. Sum of potentials in lead 1 and 3 is equal to potentials produced in lead 2. See, what are the potentials picked up in 1 and 3? When you sum up, it will be equivalent to the potentials alone in lead 2. For example, lead 1 we got 4, lead 3 we got 6, 6 plus 4, 10. Lead 2 will be 10. Because the potentials are generated in that way. It is an equilateral triangle, Ithoven's triangle. Now, what do the leads inform? What does the leads tell us? See, in this diagram, I have shown you the limb electrodes first. Chest electrodes I have not shown you. In this diagram, I am demonstrating the limb electrodes. See, previous slides we have seen we have three unipolar limb electrodes and we have bipolar limb electrodes. Unipolar limb electrodes are AVR, AVL and AVF, and the bipolar limb electrodes are lead 1, lead 2 and lead 3. Now see, AVR is looking upon the right atrium, AVL on the interatrial septum, lead 1 on the left atrium, lead 2 in the at the interventricular septum, AVF exactly interventricular septum, and lead 3 is the right ventricle. So this and chest leads, if you see V1, V2, look at the right ventricle. So this is the heart. This is how we have placed the electrodes. V1, V2, right ventricle. V3, V4, exactly at the septum. V5, V6 on the anterior wall and lateral wall of the left ventricle. Please understand. V1, V2, look at the right ventricle. V3, V4, septum. V5, V6, they look at the anterior wall and lateral wall of left ventricle. Anterior and lateral wall. Now, recording an ECG, explain the procedure to the patient, obtain consent and check for allergies, check cables are connected, ensure surface is clean and dry, ensure electrodes are in good contact with the skin, enter the patient data, wait until the tracing is free from artifacts, request that patient stay still, push button to start tracing. Before disconnecting the leads, ensure the recording is free from artifact. The paper speed should be 25 millimeter per second. For normal standardization of 1 millivolt, 10 millimeters are taken. As I told you, vertically the graph paper will tell about the voltage, and horizontally will tell about the time. Lead placement is correct. ECG is labeled correctly. I mean, the patient name, age, data, everything. Now, as I told you, we always take a 12 lead ECG, 6 limb leads and 6 chest leads. Limb leads are AVR, AVL, AVF, lead 1, lead 2, lead 3. Chest leads are V1, V2, V3, V4, V5 and V6. So total we have 12 leads. So what does these 12 leads tell about? It monitor patient's heart rate and rhythm. It evaluates the effects of diseases or injury on heart function. It detects presence of ischemia or damage. It evaluates responses to medication, that example antidysergemics. Obtain baseline recordings before, during and after surgical procedures. For any, suppose a patient is posted for an orthopedic surgery or a pneumonectomy or cholecystectomy. So before, we will take the baseline ECG to ensure his heart is working in good condition. Now, what is a normal ECG? Now, coming to the normal ECG, normal electrocardiogram consists of a P wave, a QRS complex, a T wave, sometimes an U wave will be appearing. P wave, QRS complex, a T wave, and sometimes a U wave will be seen. Always an ECG starts with P wave. Now, impulse conduction and how the graph appears. When the impulse is generated at SA node and it travels to AB node and bundle of His, that means atria are depolarized, you get a P wave. See, carefully understand. From sinoatrial node to atrioventricular node to bundle of His, atria are polarized. That means atria go into contraction. You get a P wave. From bundle of His to bundle branches, you get QRS complex. Then to Purkinje fibers, you get the T wave. That means when atria again goes into polarization. Now P wave. P wave is produced by atrial depolarization. See, whenever atria is depolarized, we get a P wave. It is always upright in lead 1 and 2. When you see the ECG, 12 leads will be given on the paper. So when you should always remember in lead 1 and lead 2, it should be upright. See. See, this is an isoelectric line. Any wave above the isoelectric line is considered as a positive deflection. Any wave below the isoelectric line is considered as negative deflection. So, So a P wave is always a positive deflection. It is above the isoelectric line. It is always a positive wave. It is always positive wave in lead 1 and 2, and it can be variable in lead 3. Lead 3 it can be a negative wave or a positive wave, but it is mandatory that lead 1 and lead 2 it should be always upright. Duration is less than 0.1 second. The duration of the P wave should be 0.1 second. Now let us revise the ECG paper here. See, I told you 5 small squares become 0.2 seconds, and the P wave duration is 0.1 second. That means exactly half of this large square the P wave should be present. I hope you are understanding how to calculate it. Exactly half the P wave should be present, because one large square is 0.2 seconds. The duration of P wave is 0.1 second. Now the shape should be rounded. P wave should always be rounded. Normal P wave preceding QRS complex with normal PR interval indicates that the heart is running in sinus rhythm. A normal P wave that is upright prior to QRS complex, in front of the QRS complex with normal PR interval. This is P wave, Q wave, R wave, S wave and T wave. So PR interval means from where the P wave ends and from where the R wave starts, it is PR interval. So a P wave in front of QRS complex with normal PR interval, if you find out, then rounded shape P wave, then you should understand that the heart is running in sinus rhythm. That means the sinoatrial node is the pacemaker of the heart. Tall peaked P waves is called as P pulmonal. Instead of rounded P waves, if you see a tall wave or peaked P wave means something like this. If you see here in this position, a P wave like this, tall and peaked P wave, then it is called as P pulmonale. So P pulmonale, tall and peaked P waves are called as P pulmonale. They are seen in tricuspid stenosis. That means your tricuspid valve has been blocked. Tricuspid valve is present on in between the right atrium and right ventricle. Broad and notched P wave is called as P mitral. If you have a broad P wave with a notched one, then I will show you. See, something like this. Suppose if you see a broad and notched P wave like this, broad and notched P wave, then it is called as P mitral. Tall and peaked P waves are called as P pulmonale. It is seen in tricuspid stenosis. Broad and notched P wave, it is called as P mitral. It is seen in mitral valve stenosis. Absent of P wave, suppose you don't have a P wave, directly PQRST wave is starting, then it is called as, that means that indicates absence of P wave indicates that your pacemaker is other than sinoatrial node. That means your sinoatrial node is, your heart is not in sinus rhythm. Sinoatrial node is not producing the what do you call the potentials. Some other, maybe atrioventricular node or Purkinje fibers is producing. Then in atrial fibrillation, P wave is replaced by sawtooth F waves. They are called as flutter waves, like this. So sawtooth appearance, these are called, it is seen in atrial fibrillation. The P waves, मैडम सर ने बताया एक काम, इसमें स्टूडेंट्स हैं हमारा बीपीटी, इनका स्टेटस बताना है, पास से फेल है या इंटर्नशिप में है।
तो सारे का कैसे पता चलेगा? जैसे बीपीटी 16 बैच के सारे,
जितना आप जानते हैं लिख दीजिए,
नहीं,
जितना मैं जानता हूँ मैं लिख देता हूँ।
नहीं आप नहीं समझ, तो मतलब 16 है, ऐसा तो नहीं है कि
ललित पास हो गया मैडम,
अच्छा
इंटर्नशिप में आ गया।
ओके ये स्टूडेंट की नेम यहाँ लिखा है, मुझे लगा पूरा बैच पास
नहीं
है।
नहीं स्टूडेंट।
अच्छा
आदर्श है, आदर्श हमारा नहीं है, BRAT का है। ऐसे पेंसिल से लिख लीजिए, पेंसिल
पास लिखना है और दूसरा लिखना है
पास्ट फाइनल ईयर।
अच्छा पास ये
स्टेटस लिखना है मैडम, पेंसिल आपको ही दिया मैंने सुबह।
वो लेकिन
जितना आप जानते हैं लिख दीजिए, जितना मैं जानता हूँ मैं बताता हूँ, मेरे क्लास होते याद। ओके, atrial fibrillation, P wave is replaced by F waves. At that time we will not be calling as P wave, we will be calling it as F wave. The F wave matlab flutter waves, that means atrial fibrillation is there. Then coming to the PR interval, PR interval is also called as PQ interval. One same, see here, this part, PR or PQ is the same. Need to share again. Hello, are you all online? Hello.
Yes, sir.
1 minute, some issue has come. I'm unable to share that slides. Could you see the slides? Hello?
Yes, sir. Yes, sir.
Okay, okay. Okay, next we are discussing about PR interval. It is also called as PQ interval, one and the same. It is the interval between the beginning of P wave to beginning of QRS complex. Normal range is 0.12 to 0.2 seconds on an average of 0.16. So 5 small squares, it should be within the 5 small squares. Okay, it should not be more. Now, why you get a PR interval? It is because of atrial depolarization plus AV nodal delay. Because of the nodal delay in the AV junction. So, because of that, you get PR interval, which is isoelectric. That means it exactly comes over the isoelectric line. See, this is in the figure. That is the PR interval. Okay. Now let's see PR interval variables. Right? Rise in PR interval occurs in heart block. Whenever the duration increases or voltage increases, voltage, as I told you, it should be isoelectric. If there is increase in the voltage, or if the duration is more, it indicates heart block. Next, QRS complex, very important and complicated. It is the sequence of deflections due to ventricular depolarization. So the whole QRS complex talks about ventricular depolarization. Q wave, it is the negative deflection of QRS complex. R wave, first positive deflection of the QRS complex. S wave, negative deflection of the QRS complex. Duration, it is from the beginning of Q wave to the end of S wave, it is 0.08 to 0.1 second, 2 to 2.5 millimeter. Shape of QRS complex, limb leads, how the shape should be, shape of the QRS complex. In limb leads, how it should be. Limb leads matlab, as I told you, we have 6 limb leads. AVR, AVL, AVF, lead 1, lead 2, lead 3. So in this, the ECG machine is arranged so that when a depolarization wave spread towards a lead, the stylus moves upwards, and when it spreads away from the lead, the stylus moves downwards. Did you understand this point? Hello? Hello? Hello?
Yes, sir.
Did you understand this point?
Yes, sir.
Okay. So if the QRS complex is predominantly upward or positive, that is R wave is greater than S wave, then the depolarization is moving towards the lead. If predominantly downward or negative, that is S wave greater than R wave, the depolarization is moving away from that lead. When the depolarization wave is moving at right angles to the lead, the R and S waves are of equal size. Now, cardiac axis. Normal cardiac axis is downward and towards the left. That means usually the impulse generation will be towards downward and towards the left side of the heart. In the I will show you. See, here it is towards the downward and towards the left side. That is, the wave of depolarization travels from right atria towards the left ventricle. The wave of depolarization travels from right atrium towards the left ventricle. When the impulse travels towards a positive electrode, there will be positive deflection on the ECG. If the impulse travels away from the positive electrode, a negative deflection will be seen. Now this is the cardiac axis. Leads AVR and 2 look at the heart in opposite directions. See, this is how we have placed the limb electrodes. Exactly, AVR and lead 2, they look heart in opposite direction. Seen from the front, the depolarization wave normally spreads through the ventricles from 11 o'clock to the 5 o'clock. Suppose this is 11 and this is 5. So your depolarization wave travels from 11 o'clock to 5 o'clock. This is known as normal cardiac axis. If someone asks you what is normal cardiac axis, 11 o'clock to 5 o'clock. Okay, this is how the depolarization wave travels. So the deflections, as I told you, if it is moving away, you get a negative electrode. If it is moving towards, you get a positive deflection. So the deflections in lead AVR are normally mainly downward, negative, because the deflection is moving away from the AVR. If the deflection move away from an electrode, at that electrode you get a negative impulse. If it is moving towards an electrode, at that electrode you will see a positive deflection in the QRS complex. So the deflections in VR are normally mainly downward, negative, and in lead to mainly upward, that is positive. The average direction of spread of the depolarization wave through the ventricles are seen from the front is called as cardiac axis. The direction of the axis can be derived most easily from the QRS complex leads 1, 2, and 3. A normal 11 o'clock to 5 o'clock axis means that the depolarizing wave is spreading towards leads 1, 2, and 3 and is therefore upward deflection in these leads. The deflection will be greater in lead 2 than lead 1 and 3. If the right ventricle is hypertrophied, suppose there is a right ventricular hypertrophy, the axis will swing towards the right instead of left. The deflection in lead 1 becomes negative and deflection in lead 3 will become more positive. This is called right axis deviation and is associated with pulmonary conditions and with congestive heart disorders. When the left ventricle is बता दिया सर नेहा मैडम को दे दिया When the left ventricle is hypertrophied, the axis may swing to the left, so the QRS complex become predominantly negative in lead 2, lead 3. This is called as left axis deviation. Left axis deviation is not significant until QRS deflection is also predominantly negative in lead 2, and the problem is mainly conduction defect rather than left ventricular hypertrophy. I will end up over here for today. Tomorrow we will continue this along with TMT, treadmill test. Okay? Hello? Hello?
Yes, sir.
I am ending the lecture over here right now.
Okay, sir.
Okay? The rest of the ECG and TMT, treadmill test, stress ECG, we will discuss tomorrow.
Okay, sir.
Okay, go through the slides, what I have told you. I think very basically I have explained. You will
Yes,
go
sir.
through it easily. Okay?
Okay, sir.
Okay, bye. See you.
Thank you, sir. Excuse me.